Okay, so we just finished topical anatomy on the skeleton, but the reality is when you walk into a clinical setting and you're evaluating a patient, they're gonna have skin on their foot and their toes. So the goal of this part of the lab is really to palpate and to show you structures on an actual live patient. You'll recall that I said I always start in a systematic order. So for this particular patient, I'm gonna start with the dorsum or most anterior aspect of the foot. So what I'm gonna start with first is the lateral side, just because I think you'll have a better view of that. So the first thing that I'm going to palpate on the lateral side is the fifth phalange. So here is the fifth phalange. And as you'll recall, remember phalanges 2 through 5 have 3 different phalange pieces. It has the proximal phalangeal piece, has the middle phalangeal piece, and it has the distal phalangeal piece. So this overall structure is called your fifth phalange. If I were to flex the patient's toes, you guys, and palpate this structure right here, this little knuckle-like structure, it would be called your metatarsal phalangeal joint. As I progress upward or more proximally, I am now on her fifth metatarsal. And you guys all might see a bony prominence poking out at you right here. This bony prominence is what's called the styloid of the fifth. It's like a hook-like structure. What we'll learn about in the lecture component of the class is how this structure is often fractured and really has poor healing rates. And we'll talk about that in the lecture portion of the class. So we've got the fifth metatarsal here. We have the fourth metatarsal here. We have the third metatarsal here, the second metatarsal here, and then we have the first metatarsal here. And it's our first metatarsal that has the largest, what is called metatarsal phalangeal joint. You guys can see that here. So this is the first metatarsal phalangeal joint. And then again, like I said in the topical anatomy section, we have the most proximal portion of that phalange and then the distal portion of that phalange. And then if we bend that toe, we have what is called an interphalangeal joint, right? So those would be the phalanges that we've just discussed. We have the first through 5 metatarsals, which are the longest bones in the feet. And then remember, as we progress upwardly or proximally from that first metatarsal, what we're going to enter into is what's called the first or middle cuneiform, right? Doesn't look as clean here as it did on that bony skeleton. And then if we progress laterally just a little bit more and we're over that second metatarsal, we are now over what is called the middle cuneiform. And then if we progress a little bit more laterally and we're aligned with that third metatarsal right here, then we know that we're on that lateral cuneiform. As we continue to progress laterally, remember we talked about the cuboid. That cuboid is just a little bit what we would say, so here's styloid of the fifth. What we would say about that cuboid is it is just proximal to the styloid of the fifth, okay? So it's right here in terms of palpation technique. One way to know that you're on the cuboid is to do what we call a plantar dorsal mobe, and you'll feel that cuboid moving in between your thumb and your index or middle finger. So we have metatarsals 1 through 5. We've covered the styloid of the fifth. We've covered the cuboid bone, which is here, yes. We've covered cuneiforms 1, 2, and 3. And as we progress proximally, what I do is I change the way in which I'm actually palpating. What I'm gonna do here is take a centralized approach. I'm gonna hug the patient's foot a little bit, and I'm gonna slide forward until I get into the crevice of the patient's foot. What I know about this is where the talar dome is. And as I take her into dorsiflexion, I'll feel it, but I'll mostly feel it when I plantar flex her foot. You'll feel that talus pop out at you. So this is a talar dome of the talus. I see that? It's central to the actual ankle. If I invert my patient's foot, then I'm now on what is called the lateral dome or lateral head of the talus, right? And as we're in this position here, we could also palpate the fibula, right? The most lateral bone in the lower limb. And then if we just drop inferiorly And posteriorly, we are now on the calcaneus, which is by far one of the largest bones in the foot. So as we progress from this talar dome section, what we're going to do now is have our patient switch limbs so we can actually look at the medial side of the foot. So now I'm on my patient's medial side, so orient yourself. This is the medial side. It's the side that's most closest to our patient's midline, okay? So this is our first metatarsal, just for review. If I were to take my fingers and slide up my first metatarsal, the bony prominence that I would come to is what is called the navicular bone. This is one of the most medial aspects of the foot, one of the larger bones of the foot, okay? So medially, what we also have is the medial calcaneus, and then proximal to that, we have the distal portion of the tibia, okay? Now, when we think about the foot is really broken down into three what are called sections, okay? The first part of that section is what's called the forefoot, okay? The forefoot is comprised of your phalanges and your metatarsals, and then it's broken down into your midfoot, which is comprised of all of your tarsal bones. So your midfoot contains which bones, you guys? Right, I hope you said it. It's going to contain your cuboid, it's going to contain your navicular, it's going to also contain three other bones. It's those cuneiform bones. And then last but not least is the hindfoot, which consists of the calcaneus, right? And what's the other bone? The bone that sits on top of that calcaneus, which is known as the talus. So three sections to the foot: the forefoot, comprised of the phalanges and the metatarsals; the midfoot, which is comprised of what we call the tarsal bones; and then last but not least, the hindfoot, which is comprised of your calcaneus and your talar bone. So on the posterior aspect, and you guys might be wondering, why did I save this one for last? Because what we don't want our patient to do is keep flipping over, right? What we learn in the clinical setting is that when we keep making our patient shift or move or change positions, is they lose confidence in us as a clinician. So my last palpations are to the posterior aspect of my patient. Most proximally, what we're going to palpate are the medial and lateral gastroc heads, medial and lateral gastroc heads. So I'll say that again, medial and lateral gastroc heads. We're going to palpate the Achilles tendon, which is located here and most distally. What we know about the gastrocs, which you guys should all be telling me, is that they start proximally as two muscles, yes, and then they come down distally and become one via the Achilles tendon, where they distally attach to the calcaneus, right? I'm sure you all said that to me, right? Okay, so what we also know is that if we were to transect and reflect, right, those gastrocs, that deep to those gastrocs would be the larger soleus muscle, right? We would all say that the gastroc's major role in movement is a forceful plantar flexion, right? So we're gonna have our patients push against the gas pedal or plantar flex, and we'll see that patient's gastroc contract, yes? We have the Achilles tendon. And we'll talk about this in the lecture, but this is a really good time to look at your patient's feet, because what we can see in the posterior segment of the foot is wear and tear, the way in which they are wearing and tearing on their shoes, right? And you'll get a lot of that information based on how this portion of the calcaneus looks. You'll see blisters, you might see redness, you might see hard ossifications. You'll see all kinds of things that'll tell you how that patient is actually wearing or how that foot is behaving in that particular shoe. So what we want to look for when a patient comes in and complains of pain over the Achilles tendon really are three pathologies. Is it Achilles tendonitis, probably the one that we look for the most, or could it very well be that they've irritated the bursa, right? So there are two different types of bursa that are located within the Achilles tendinous structure. The first and most superficial bursa is what's called the subcalcaneus bursa. So it is this guy. We're just literally going to pinch that skin. Do you guys see that? A little bit of a pinch. If a patient has a positive pain with this pinch test, then we know that their subcutaneous calcaneal bursa is inflamed. But what we also have is a deeper bursa within the Achilles tendon structure. So if we pinch on the outside of that Achilles tendon right here, and if that patient has pain, then what we can say about that is that that subtendinous calcaneal bursa is inflamed. So now we're moving into the range of motion segment, which if we're looking at order in the way that we do our evaluations, we're going to palpate, we're going to look at range of motion, right? And so now we're moving into the range of motion segment. Now, most often in the clinical setting, we will just eyeball the range of motion, but number one, we're required to teach you how to actually get an objective assessment of motion. And so this is the way that we do that in the clinical setting. This tool right here is called a goniometer. And the goniometer really is comprised of 3 different components. The first component is the movement arm. Okay, so we've got the movement arm here. Second component is the stationary or fulcrum arm. And then that third component is what you see here, which is the central portion of the goniometer. Okay, so we have the fulcrum or the stable arm, we have the movement arm, and then we have the most central portion of the goniometer. Goniometers are most often used as one of the most reliable objective assessments of range of motion. So we're going to show you how to measure both the ankle and foot range of motion so you have an objective assessment within your clinical patient notes. So we talked about measuring 4 different toe ranges of motion: toe extension, toe flexion, toe abduction, and toe adduction. Okay? Remember, the big deal with goniometer is knowing your anatomy. Okay? We have to know the anatomy of the goniometer. This is the movement arm. Yes? The one with the big round bulb is what we call the stationary arm. So in lab, if you're moving the stationary arm, you're doing the wrong thing. The stationary arm never moves, okay? The center portion is most often what we place on an anatomical structure to help us align our structures. We're going to start with measuring toe range of motion first. The only toe that's important in terms of range of motion is truly the first metatarsal. So I'm going to talk in terms of goniometer anatomy. Okay, so the stationary arm is going to be aligned to the first metatarsal. The central portion, or this metal piece of the goniometer, is going to be aligned to the first metatarsal phalangeal joint, okay? And then the movement arm is going to follow the first phalange. So let me line that up. Metal portion goes right over the first MTP, or metatarsal phalangeal joint. And then if you can see right here, there's a black line on the goniometer. This black line exists across all goniometers. It's what's called our bisection line. So what we want to make sure is that that black line on the stationary or fulcrum arm is going through the first metatarsal. Once we have that done, what we're going to instruct our patient to do is to either bend their toes downward, which would capture toe flexion, or they're going to bring their toes upward, which would capture toe extension. Now, this, of course, is an assessment of active range of motion. I most certainly could assess passive range of motion as well. So what I have my patient do is go ahead and bend your toes down towards the ground, and you guys will see that I am literally only moving the movement arm of the goniometer. Want to make sure that this black line on the goniometer is bisecting that first phalange. So what you'll see is that there are numbers on this dial, right? And these numbers on this dial will tell you the amount of range of motion in degrees, okay? So let's start over. If I'm starting at 0, I'm going to be looking at the black numbers on my dial to tell me how many degrees of motion does this patient have for toe flexion? So go ahead and flex for me, patient. Great. And so this patient has approximately 40 degrees of toe flexion, okay? And then we're gonna go back to neutral, which is 0. We're gonna have that patient extend for us or bring her toes up. This patient has approximately 25 degrees of toe flexion. So the question really becomes, class, what are normative values? In other words, what's normal so that you can figure out what's outside of normal, yes? So when we're thinking about toe flexion, the normative for toe flexion could be anywhere between 40 to 60 degrees of toe flexion. For toe extension, the normative could be anywhere from 20 to 30 degrees of toe extension. And this becomes important because if a patient is lacking, right, or has less than that, we have to figure out how are we actually going to treat that particular patient. The next ranges of motion that we're going to do are two that are really important. That's going to be toe abduction and toe adduction, okay? So how are we going to position this? I want my stationary arm, makes sense, to be aligned to that tibia. And I want my center piece or the metal piece to be right over that metatarsal phalangeal joint. So my center piece is going to be right over that metatarsal phalangeal joint, okay? My movement piece, everybody see that? Is going to go in the center of the phalange, or you could use the toenail as a landmark. So the center of the toenail. So with all of my pieces in place, I am going to passively abduct her toe because it's almost impossible to abduct. And I'm going to measure her toe abduction, okay? So I'm here, I'm moving her foot into abduction. She's got approximately 15 degrees of abduction. And if I wanted to assess first ray adduction, what I would have to do is bend the toes down in such a way that I'm allowed to go into that adduction moment, okay? So I'm gonna put my goniometer back on, make sure that it's aligned, metal piece right on that metatarsal phalangeal joint, the fixed or fulcrum arm going through the tibial crest. And then last but not least, I want to make sure that I'm bisecting that toenail. I'm going to push those toes down. I'm going to adduct that toe. And then what I'm looking at is how many degrees of motion does my patient have? She has approximately 5 degrees of toe adduction. Now, there's a reality inherent in this. Patients are going to have more abduction than they are toe adduction. And I'm wondering if you guys can tell me the reason for that, right? Well, what we know about toe adduction is what? They have a block, right? That block is what? The second metatarsal and also the second phalange, right? When we move into toe abduction, do we have that block? Not anymore. So now we're going to actually measure range of motion of the ankle, which is honestly the one measurement that we would use more often when compared to the toes. Toes, very rare clinical measurement, but certainly ankle measurements are important, specifically after an ankle sprain. So we're going to talk about 4 different measurements for range of motion. The first and probably most common is going to be dorsiflexion range of motion. So dorsiflexion is when those feet or toes are going towards the shin, okay? So in terms of our goniometer anatomy, what we want to make sure of is that the fulcrum or fixed arm, right, is going to be on the lateral side of the limb. We want to make sure that this metal piece right here is going to be on the lateral malleolus, and your movement arm is going to be moving with the 5th metatarsal. So let me just show you positioning first. Okay, so metal piece right on the center portion of your fibula. You guys might say, well, how do I know that this is where it needs to be? So the first thing I'm going to do is have to find that fibular head. And then what I typically do, I'll extend my finger out to make sure that it's in alignment. Okay, guys? So now that I know that this is aligned, now that I have my metal piece where I need it to be, what I typically do clinically is just place the goniometer at 0 degrees, or for some of you, what we consider to be 90 degrees, okay? And then what I'll have my patient do is go ahead and dorsiflex. Keep going, Suze. And I'll look and I'll make sure that this line is very parallel to that 5th metatarsal. Keep pushing, Suze, if you can. Great. So in this instance, what we would say is Suze has about 5 degrees of dorsiflexion range of motion. Now, you all might be saying, well, what's normative? Normative is 15 to 20 degrees of dorsiflexion range of motion, which means what about our patient? That she is lacking dorsiflexion range of motion, which is a terrible thing to lack. Because what that means is that she's lacking dorsiflexion, the foot's in more plantar flexion, which then means she's more susceptible to ankle sprain moments. So I would ask my patient a historical question. Have you sprained your ankle before? Yes. Have you sprained your ankle multiple times? And one of the reasons that our patient might be saying yes is because that she's not getting enough dorsiflexion range of motion, okay? Now we're gonna move into plantar flexion, and believe it or not, the setup is the same as it would be for dorsiflexion. So stationary arm here, metal piece right at the distal portion or tip of the fibula. I'm just gonna measure to make sure that this is bisecting that fibular head. And then what I'm gonna have my patient do is I'm gonna stabilize here. I'm gonna have my patient point their toes down as far as they can go. And then I'm gonna take that goniometer and I'm gonna do the same thing. Now you're gonna be tempted to take it all the way down here. But remember, we want this black line to be very parallel to that 5th metatarsal. So what we're going to do here is we're gonna start again, and we're gonna start at 90. Suze, go ahead and flex for me. What I'm going to do is look at how much range of motion Suze has. So Suze has approximately 48 degrees of dorsiflexion range of motion. So for plantar flexion, she's not lacking, because the normal range of motion for plantar flexion is 40 to 50 degrees of plantar flexion range of motion. But with that being said, there is a subset of population who will have upwards of 70 to 80 degrees of plantar flexion. Those people are known as dancers, acrobatists, and gymnasts, right? Because they're gonna spend a lot of time in that point position or plantar flex position. So don't be alarmed if you get a patient who has 70 to 80 degrees of plantar flexion. That would be their, what we call, new normal, okay? So we've done dorsiflexion range of motion. We've completed plantar flexion range of motion. Now what we're going to do is assess inversion and eversion range of motion. And what you might notice as you're doing this is, number one, when we move into inversion, we get a lot more inversion than we do eversion, right? And if you guys are stewards of the anatomy, what you would know is that this fibula, right, on the lateral side comes down more inferiorly than its medial counterpart, the tibia. So for that reason, we can't really move into eversion as much because that fibula is blocking us from moving, right? Whereas on this inversion moment, the tibia isn't as long, so we can get more motion of the foot. So you should expect that when you're measuring your range of motion. So with that said, with inversion range of motion, what we want to do is place the stationary arm of the goniometer along the tibial crest of the tibia. Want to place that metal portion of the goniometer in the center of the talar dome. So you'll have to know your anatomical structures. So we're going to place that in the center of the talar dome to make sure this is aligned to the tibial crest. And this movement piece is going to bisect the second phalange. Okay? And it's going to move with the second phalange. It's important to keep this in mind. So if I say to my patient, please take your toe and point it inward, I'm going to move in this direction here, and I'm going to see that Suze has 35 degrees of inversion range of motion, right? You might be saying, well, what's normal? About 15 to 20. Right? So this is a patient who either spends a lot of time in an inversion moment, right, and has stretched those ligaments because she has 15 more degrees of inversion range of motion than the normal person would, okay? And then what we're gonna have our patient do is go back to just a neutral position, and then we're gonna have her push her pinky toe out as far as she can. So I'm not kidding you guys when I say that she has exactly 0 degrees of eversion range of motion, but let me take off the goniometer so you can actually see that visually with your own eyes. I'm not making this up, right? The ideal would be, if we're measuring eversion range of motion, that your patient would have about 5 to 10 degrees. And so what that tells me is she's not maximizing the appropriate amount of motion in the foot. But it also tells me that she's spending more time in which direction, guys? If she can't get an eversion, then she has to be spending more time in inversion, right? Which obviously tells us something. She had increased plantar flexion. She has increased inversion, not enough eversion. Does it make sense why she continues to sprain her ankle over and over again? These are the things in your clinical practice that you have to pay attention to if you really, truly want to figure out what is going on with your patient. Okay, so part of every evaluation, we typically will do a quick vascular check just to make sure the vascular structures are intact, more specifically after an acute emergent injury. So there are 2 pulse sites that we can check in the foot and the ankle. The first one in the ankle is what is called the posterior tibial pulse, right? Its name gives it away. It is just posterior to the tibia. So what you're gonna do is take your 2 fingers, typically your second and third fingers or index and ring fingers, you're gonna place them just posterior to that tibia. And what that'll allow you to do is capture their pulse, right? If the pulse is present, your patient's in good shape. If their pulse is absent, then we're concerned about blood flow going to the foot and amputation, so that's a medical emergency, right? What happens if we have an injury to the ankle and we need to check a pulse more distal? And we have a pulse site in the foot, which is really hard to capture. Sometimes I can't even get it. It's called the dorsal pedal pulse. And so that pulse is typically between digits 2 and digits 3. And it is really hard to capture. But right about here is where you're going to find that dorsalis pedal pulse. Again, you're going to check this pulse if you have an injury to the ankle because you want to assess blood flow distal to the injured site. Okay, so we've got posterior tibial pulse, which is most often assessed after a limb injury. We've got dorsal pedal pulse, which is most often assessed following an ankle injury. And if you can't find either of those and you're concerned about blood flow, then the next best bet would be what's called a capillary refill. Capillary refill requires you to take your thumb and index finger to place it over that first fingernail bed of your patient and to squeeze. You're going to squeeze for 2 seconds. Then what you're going to do is release, and what you're looking for is that nail to turn back to its normal color within 2 seconds. If it doesn't, if it stays white for longer than 2 seconds, one of 2 things are happening. One, either the room is extremely cold and the patient doesn't have enough blood flow going to the extremity. We can warm it up and we'll be fine. Or 2, they have no blood flow going to that extremity and they're getting ready to lose that limb. So there are different ways to assess vascularity in the foot and the ankle. Again, you can do a capillary refill, release, and does it turn back to its pinkish color in 2 seconds? We can do a dorsal pedal pulse, or we can do a posterior tibial pulse. So we have covered palpations, we have looked at ranges of motion. Now what we're going to do is get into more activity part to see what can our patient do. So we're going to actually start testing the muscle. We do that through a process called manual muscle testing. So what we're going to do is start with the extensor digitorum longus first. So the extensor digitorum longus muscle is on the dorsum of the foot. As its name implies, if it actively contracts, it's going to cause toe extension of digits 2 through 5. So if we want to manually muscle test a muscle, we're going to take our finger, we're going to push those toes in the opposite direction than we want them to move. So because this is a toe extension exercise, what I'm going to do is place those toes in flexion, stabilize the tibia here. What I'm going to tell my patient to do is go ahead and push up against my resistance. And what you guys will see are a few things. I'm working hard, but so are her tendons. Do you guys see that? Her extensor digitorum tendons, tendon 2, 3, 4, and 5. So what I'm going to do here is I'm going to hold it for 5 seconds. And then what I'm going to say is hold your toes up. Keep them up. Don't let me pull you down. And I'm trying to break her or pull her down. In a strained patient, what you will see is what's called a positive break test. So what happens is I stabilize, I pull the toes down into flexion, go ahead and pull up, and then don't let me pull you down. They can't resist that, right? That's a positive. That'd be positive for a strained extensor digitorum longus muscle. Now the toe, the first ray, has its own set of muscles called the hallucis or hallucis muscles. And so for extension of the great toe, you can do this many ways. The way that I've seen being able to control it best is a stabilization here, use of my thumb over the first phalange, pulling that first ray into flexion, and then go ahead and pull up against my finger. Good. You'll see that flexor hallucis tendon pop out at you. And again, hold, don't let me pull you down. Hold, 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 hold. And you'll see me trying to pull her down. Now a positive break test would be hold, don't let me pull you down. And she doesn't hold, right? Successfully. So that's manual muscle testing of the extensors of the foot. If it's digits 2 through 5, come on up. We're testing the extensor digitorum longus. If it's digit 1, come on up. We're testing the extensor hallucis longus. Okay. Next on the list are the fibulari muscle group. And there really are 2 different testing positions that we'll have to do. The fibularis brevis and longus are both everters of the foot, and they are also plantar flexors of the foot. So there's 2 motions that they do. They evert and they plantar flex. So let me do that for you. They not only go here, but they go here. Does that make sense? So longus and brevis are going to go down into plantar flexion and into eversion. So you're going to have to test both of those motions, right? So the first thing I'm going to do is stabilize my patient's tibia. Yes. The next thing I'm going to do is take this hand, place it right here. So essentially that index finger is right over that 5th styloid or styloid of the 5th. The rest of my palm, however, is right over that metatarsal. Does that make sense, guys? Now, I am not cupping or hugging the foot. Instead, I'm doing what is called a lumbrical grip. Okay. So I'm here. I'm going to tell Suze, go ahead and push me down and out. Okay, so go ahead and push down and out. Hard, 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 hard. And you guys can see the fibularis muscle popping out at you, right? So you know you're doing it right. And then what I'm going to say is don't let me push you in. Are you ready? Good. Okay. Now, the fibularis tertius is a part of the fibulari muscle group, but it has a separate action at the foot and the ankle. It is an everter, like all fibulari muscle groups. But this fibularis muscle actually dorsiflexes the foot as well. So what we're going to do is something a little bit different. I'm going to need Suze to go up and out this time. So what I'm going to do is place my hand here. Do you guys see that? You might need 3 fingers, right? I'm pretty good with 2. But so right above that metatarsal phalangeal joint on the lateral side, I'm going to be here. And what I'm doing is giving her a little bit of touch on the dorsum of the foot. And this is important because it's going to tell her to go up into dorsiflexion, you guys. Okay. So I'm here. Ready, Suze? I want you to go up and out. And if we're good, we'll see it pop out at us right here, you guys, okay? So if I'm doing fibularis longus and brevis, they're plantar flexor everters, so down and out. But if I'm doing fibularis tertius, I'm gonna have her go up and in, up and out, sorry, up and out, okay? And so then the break test would be, don't let me push you down and in. The next muscles on the list are the tibialis anterior and tibialis posterior muscle. Tibialis anterior is the largest muscle on the anterior limb in the anterior compartment. Its major role is dorsiflexion, but also inversion. So we're going to have that patient do a combination movement of dorsiflexion and inversion, okay? So my hand placement is going to look a little bit different for the tibialis anterior. My hand placement is going to be here, right? So right on that first MTP, see that? I'm gonna have her go up and in, up and in. Don't let me pull you down and out, okay? And you'll see that tibialis anterior tendon pop out at us, right? Make sure you're stabilizing. For the purpose of this video, I am not, so that you can actually see my hand placement, but your stabilization should always be to the tibia. Because if it isn't, what happens is the patient will roll all around on the table. And so stabilizing them gives them really good feedback. So again, ready? We're going up and in. Got it? Okay. The next muscle, or the sister muscle to the tibialis anterior, is the tibialis posterior. Tibialis posterior, remember, is a part of that Tom, Dick, and Harry group, right? So it is on the medial side of the leg. So automatically, it's an inverter, right? The difference between the tibialis posterior and tibialis anterior is that the posterior also plantar flexes and inverts. So here's my positioning for a plantar flexion inversion moment. Notice that I shift my body a little bit. Stabilization still going to be here at the tibia, but the way in which I hold the foot is going to look a little bit different, right? I have a little bit of contact with the plantar surface of the foot, but I also have contact with that first MTP. So I'm gonna tell my patient to do is go ahead and push down and in. Go ahead, go, 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 go. And you'll see tibialis posterior pop out at you as you're doing this, okay? So then my direction is hold that, okay? And don't let me push you up and out. And so now I'm trying to push up and out, okay? One note while we're doing manual muscle test, you're going to be stronger than your patient. So there isn't a need to overbear on that patient's tendon, right? I'm not gonna get in here like this and try to yank them, right? That isn't our goal. Our goal is to see if the muscle can withstand the stresses. 2 or 3 fingers is all you need to determine that. You don't need all of your weight on that patient's structure or limb to figure that out, okay? So be very, very careful. Last but not least, we're gonna have the patient flip over to a prone position. And now what we're going to be assessing are the gastrocs and the soleus, okay? They are different. Even though they work together to plantar flex the foot, we still want to know how to differentiate between the two in the event of an injury. So if the patient's knee is extended, does that make sense? And I have them plantar flex, so go ahead and push against my hand. Then we are testing the gastrocs. This would be a gastrocnemius manual muscle test, okay? So that patient, the knee is extended, they're laying in a prone position. I'm stabilizing here, not in the knee joint itself, so about mid-gastroc. I'm going to push her into dorsiflexion, so that patient's gonna go into dorsiflexion, and then she's going to push against me into plantar flexion. Hold, Suze, okay? Now notice I'm using my body to help me, right? Because with 250-pound linemen, your attempt to do this, ready, go ahead and push, they'll just push you out of the room, right? I've had it happen a few times, so much to know that now I'm gonna use my body weight wherever possible, right? So go ahead and push against me, push, 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 push. Don't let me push you in, okay? So that would be for the gastrocnemius group. If we wanted to test soleus, so we wanted to isolate the soleus, yes? Then we would flex the knee. And you all might be sitting there thinking, well, why would I flex the knee? What we do to the gastrocs is we shorten them, we quiet them. And this is truly an assessment of the soleus by itself. So what we're going to do, what I typically do is I'll hold here. Do you guys see that? I'm not pushing her, I'm just stabilizing. My pressure is going to be on the plantar aspect of the foot. Gonna probably get right around those metatarsal heads. So right here, go ahead and push up against me. And you guys can see her foot move into a plantar flexion moment. I'm not allowing her to move in and out of knee flexion. Her knee is staying at 90 degrees and I'm stabilizing. Go ahead and push up and don't let me push you down. Okay? That would be soleus. This would be gastrocs.